Guys, in this video we'll be discussing about the management and risk stratification of non-muscle invasive bladder cancer. For better understanding of the staging, refer back to my video on staging of bladder cancer, TNM staging. So coming to the risk stratification, according to the AUA guidelines, the non-muscle invasive bladder cancers are divided into three risk groups, that is low risk, intermediate risk, and high risk. Tumors which are unifocal, low grade, TA that are less than or equal to 3 centimeters are included in low risk group, and tumors that are papillary urothelial neoplasm with low malignant potential are included in low risk group. Anything which is multifocal or more than 3 centimeters automatically gets excluded from the low risk group, and so the management differs. In low risk group, the management is single intravesical post-op instillation, which can be either mitomycin C or gemcitabine. For mitomycin C, the dose is 40 mg in 20 ml of sterile water. For gemcitabine, it is 2 grams in 100 ml of saline. Next, coming to the intermediate risk groups, I've divided them into low-grade tumors or high-grade tumors. Low-grade tumors, which are either TA or T1. TA unifocal are low-risk group, whereas TA multifocal and more than 3 centimeters and which recur within 1 year of treatment come under intermediate risk group. High-grade TA tumors also come under intermediate risk group. Coming to the high-risk groups, anything more than intermediate risk comes under high-risk group. And in addition to it, the presence of carcinoma in situ, presence of lymphovascular invasion, and presence of variant histology, and involvement of prostatic urethra come under high-risk group. In variant histology, examples are micropapillary, nested, plasmacytoid, neuroendocrine, extensive squamous or glandular differentiation. The management of these two groups differ from that of the low risk group. In intermediate risk group, the management is intravesical, chemo or immunotherapy. Chemotherapy examples are mitomycin C, gemcitabine, epirubicin, or doxorubicin. Immunotherapy is given with BCG. First, we give an induction course for 6 weeks, followed by 1 year of maintenance. After induction therapy, we assess the patient again with cystoscopy and urine biomarkers. If there is any suspect for recurrence, we take a biopsy and assess these patients and assess the histology of the recurrence. Whereas in high risk groups, the management is intravesical immunotherapy with BCG, that is 6 weeks of induction course followed by assessment and then 3 years of maintenance. In either of these groups, if there is presence of persistence or recurrence at the end of 6 weeks, it can be either a low-risk recurrence or a high-risk recurrence. Low-risk recurrence is presence of carcinoma in situ or TA papillary tumors. In these patients, give a second course of induction immunotherapy. Whereas if the recurrence is of high risk, that is anything more than carcinoma in situ and TA, that is high-grade tumors, or the presence of T1, then you go ahead with radical cystectomy. So now what are the indications of repeat TURBT? Now coming to what are the indications of repeat TURBT within 6 weeks of initial TURBT is presence of high-grade lesions. That is high-grade TA tumors less than or equal to 3 centimeters or any high-risk group, that is presence of carcinoma in situ, LVI or variant histology. You do a repeat TURBT to restage these tumors. because in these patients there can be progression. Because in these patients there can be progression. And now, what are the indications of radical cystectomy in patients with non-muscle invasive bladder cancers? These are presence of persistent tumors after induction immunotherapy, or if there is any presence of carcinoma in situ along with T1 tumors, presence of LVI and variant histology. Always give considerations for initial radical cystectomy in these patients. That is the management of non-muscle invasive bladder cancers. In short, this table is taken from the AUA guidelines. This is what I have summarized earlier. So low risk groups are low grade solitary TA tumors less than or equal to 3 centimeters, or presence of papillary urothelial neoplasm with low malignant potential. And this I have divided into low grade and high grade and explained. In high risk groups, that is high grade T1, any recurrence, T8, high grade T8 tumors more than 3 centimeters or multifocal, any carcinoma in situ, any BCG failure in a high grade patient, any variant histology, presence of LVI, or any high grade prostatic urethral involvement. So, that is the management of non muscle invasive bladder cancer. I'll see you in the next video.